So okay, good evening, everyone. Welcome and thank you for joining AAMS Journal Club tonight. I'm Nora Gashi, President of Albanian American Medical Society. As we all know, October is a Breast Cancer Awareness Month. We'll be talking about breast cancer screening, diagnosis, treatment, and also we'll be discussing some recent studies and articles. Our presenters of tonight's Journal Club are Dr. Sarah Crezio. She's currently a third-year general surgery resident at NYU Langone Health. She completed a research fellowship at Memorial Sloan Kettering, studying the molecular drivers of liposarcoma, and plans to pursue a fellowship in surgical oncology. Dr. Francesca Becciri is a fully certified ECFMG international medical graduate from the Royal College of Surgeons in Ireland, looking to continue her residency with a focus in general surgery. And the moderator, Dr. Dugajin Blakaj, who is currently an Associate Director for Clinical Operations at Radiation Oncology, the James Cancer Center. Dr. Blakaj is also an Associate Professor as well as the Director of Head and Neck Department of Radiation Oncology at the Ohio State University Wexner Medical Center. So we can start with Sarah or Francesca or Dr. Blakaj.
I'll get started.
Okay, good.
Let's do this again. All right, so hi everyone. Thank you for joining us tonight. I'm very excited to talk to you about the management of breast cancer. So I'll briefly discuss epidemiology, followed by anatomy, and then discuss screening guidelines, and move on to diagnosis, and then the multimodal treatment strategies. Breast cancer is the most commonly diagnosed cancer among US women. About 280,000 newly diagnosed women with invasive disease each year, and that accounts for about 14.8% of all new cancer cases in women. As we can see over the last 2 decades or so, the incidence and death rate have remained stable. And then the overall survival without stratifying into stages is about 90%. So a few important anatomical points. So the breast is composed of glandular epithelium. You've got fibrostroma and the supporting structures, and then adipose tissue. Each breast has about 15 to 20 lobes that are arranged in a circular fashion. These lobes each contain many lobules, as we can see here. And then these are the glands that produce milk in response to hormones. I'll have you look at the Cooper's ligaments here, which are they provide the shape and structure to the breast. They go from the overlying skin all the way to the deeper fascia, and infiltration of these ligaments by tumor is what causes the tethering that we see sometimes in breast cancer patients. You might see dimpling or deformities. And then the other component is axillary lymph nodes. So here we've got level 1 lymph nodes. These are lateral to the pectoralis minor. Level 2 nodes are deep to it, and then level 3 nodes are medial to it. In breast cancer surgery, typically, if we need to take any, we take levels 1 and 2. And then internal mammary nodes, I'll focus you here because that'll become important in our later discussion. And then you've also got supraclavicular and infraclavicular nodes. So let's review the screening guidelines. For most societies, including the American Cancer Society, American Society of Breast Surgeons, recommend annual screening mammograms starting at age 40 and stopping when life expectancy is less than 10 years. The US Preventative Task Force came up with some screening guidelines a few years back that say to start at age 50 and have screening mammograms every 2 years up to the age of 74. Their decision was based on the idea that the net benefit to women ages 40 to 49 is overall small. But again, this takes into consideration a net benefit, and it's not really individual to each patient. So I think most practitioners follow the other guidelines, where starting at age 40 and going each year afterwards. So that was for patients who have average cancer risk. Patients who are at above average cancer risk are those who are defined as having a more than 20% predicted lifetime breast cancer risk. They're recommended to have annual mammography and breast MRI annually. Women who have a significant family history of breast cancer should start 5 to 10 years prior to the youngest age of diagnosis within the family, or at age 35. But what constitutes significant family history? So typically it's breast cancer in a one or more first or second degree relative with breast cancer diagnosed at age 40 or younger. Triple negative breast cancer is diagnosed at age 60 or younger. Primary cancer of both breast and ovarian cancer in one relative, male breast cancers, ovarian cancers, and so on. Women who are also known to have the BRCA mutation should begin screening at 25 years of age with an annual breast MRI, if available. If not, mammography would be fine too. And then mammography for sure at age 30 and annually afterwards. So there are a number of tools for risk assessment so that you can calculate a patient's risk assessment. One of those is the Gale model. The Gale model came out of data from the NCI and American Cancer Society that looked at about 280,000 women from ages 35 to 74. And in this calculation, it looks at age, the age at start of menstruation, age at the first live birth of a child, the number of first degree relatives, so first degree being mothers, sisters, daughters. With breast cancer, it takes into account previous breast biopsies in the patient, whether they were positive or negative, and then the presence of atypical hyperplasia in a biopsy. Now, the Gale model doesn't actually accurately estimate breast cancer risk for women who have the BRCA2 mutation, or who have a personal history of breast cancer. So there are some other tools that can be used for that. Another important factor is treatment with radiation to the chest, so that those patients are again at higher risk. And there are other rare cancer causing syndromes, one of them being Li-Fraumeni, and that's a P53 mutation. These patients typically have breast cancer and a sarcoma. So any other breast cancer causing syndromes, you typically want to send these patients off for a genetics consultation. In terms of risk factors for breast cancer, the breast cancer mutation genes, so BRCA1 and 2, are typically the most significant ones. BRCA is a tumor suppressor gene. It confers an increased risk of both breast and ovarian cancer, as well as an increased risk of male breast cancer. To a lesser extent, it increases the risk of other cancers such as prostate, pancreatic, melanoma. And here we can see BRCA1 has a slightly higher risk of breast cancer and ovarian cancer, but lower risk of male breast cancer, whereas 2 has lower risk of breast and ovarian cancer, but slightly higher risk of male breast cancer. To test for BRCA mutations, you can do molecular testing, but to decide who to test, there's the following guidelines. So any patient who's presenting with a cancer at an age 50 or younger, triple negative tumors at an age younger than 60, Ashkenazi Jewish heritage, and breast cancer at any age, 2 or more primary breast cancers, first degree relative with breast cancer diagnosed at age younger than 50, and then 2 relatives on the same side with breast cancer and or pancreatic cancer, ovarian cancers, fallopian cancers, or primary peritoneal cancers in the family, male breast cancers. And then obviously if there's a known mutation in the family. So these patients would all be eligible for testing. And then as we discussed earlier, if you know that you have this BRCA mutation, you would start with a yearly mammogram and MRI starting at age 25. So typically it's MRI starting at age 25 until 30. And then after age 30, you do mammogram and MRI together yearly. Important is also a pelvic exam and an ultrasound with a CA 125, all starting at age 25. So after we perform a screening mammogram, we typically get back results in the form of BI-RADS. As we can see here, 1 and 2 representing negative and benign have essentially a 0% chance of cancer. So these you just continue regular annual mammography examinations. A BI-RADS 3 classification is probably benign, has a really low percent chance of cancer, but you just shorten the interval of follow-up to 6 months. So instead of an annual mammogram, you would perform it at 6 months. Anything above a 3 is concerning for malignancy, and that would warrant tissue biopsy and more follow-up. So looking at the pathology, there are 2 non-invasive epithelial cancers. Those are ductal carcinoma and lobular carcinoma in situ. Ductal carcinoma in situ is defined as malignant cells in the ductal epithelium that do not invade the basement membrane. It's typically diagnosed on mammogram as opposed to it being a discrete palpable lesion. It is considered a premalignant lesion and has an overall natural progression to invasive malignancy, anywhere between 14 to 75% chance. There's also a pretty high rate of upstaging. So after you've excised it, the risk that it would be upstaged to an actual invasive cancer is anywhere between 18 to 43%, with some reports up to 50%. So it's typically managed with excision and radiation. So lobular carcinoma in situ, even though it sounds similar, it's actually not a premalignant lesion, and again, no basement membrane invasion. However, it is a marker for the development of breast cancer, and 40% of patients who do have LCIS will end up developing a cancer in either breast. And when they do develop that cancer, it's more likely for it to be a ductal carcinoma, not a lobular carcinoma. Similar to DCIS, LCIS is managed with excision. In terms of epithelial cancers, again, we've got invasive lobular carcinoma and invasive ductal carcinoma, invasive ductal carcinoma being more common. It's also stratified into some other subtypes like tubular carcinoma, mucinous or colloid, medullary carcinoma, but I won't go into all those details. And less common, but also seen, are mixed connective and epithelial tumors such as phylloides, angiosarcoma, adenocarcinoma, and these behave differently and are managed differently than are the epithelial cancers like ductal and lobular carcinoma. All right, so moving on to the evaluation of patients who come in with either a biopsy-proven breast cancer diagnosis or just come in with a palpable mass. Things you want to ask in the history are obviously age, reproductive history, age at menarche, menopause, history of prior pregnancies, history of prior breast biopsies, and then any history of hysterectomy or oophorectomy. And all of this sort of centers around, so younger age at menarche, older age at menopause, all centers around unopposed estrogen action, which is a significant risk factor for breast cancer. So you can kind of figure that out. Any use of hormones for contraception or hormone replacement therapy, again, it all centers around how much estrogen they're being exposed to. Other things you want to ask are obviously history of a mass, any breast pain, nipple discharge, skin changes. If it's a palpable mass, you want to know the duration, whether it changes with menstrual cycle, because that might just point you towards like other types of fibrocystic disease. And then if you want to ask constitutional symptoms, any bone pain, weight loss, respiratory changes, sort of to assess for any potential metastasis. On physical exam, you want to look for masses, asymmetry, skin changes. At the nipple, you want to look for retraction, inversion, again, those Cooper ligaments. And then you want to look for any excoriation of the superficial epidermis. This is called Paget disease of the breast, and it's very typical of an underlying cancer. The dimpling of the skin Cooper's ligaments. Once again, this is also a very typical a typically tested presentation, but it's peau d'orange, and you see this these dimpling here. This is, along with the swelling and tenderness, is very typical of inflammatory carcinoma. It's sometimes mistaken for mastitis. The patient may present as, having failed antibiotics for mastitis. High suspicion to have this patient evaluated for a cancer. And then you always want to document a lymph node exam. So in addition to the physical exam, you want some imaging. Typically what you end up getting is a diagnostic mammography. This is different from the screening mammography because it's more focused on the area of interest. And then you can also use ultrasound or MRI. In terms of obtaining tissue diagnosis, there are a few different types of biopsies. You've got a fine needle aspiration biopsy or core needle. With fine needle aspiration, you can only really look at single cells or groups of cells, whereas with core needle biopsy, you can see the histological structure and get a better result in terms of the pathology. Core needle biopsy is more typically used with solid masses, whereas the fine needle is used for cystic masses. And then ultimately is an excisional biopsy that's done in the operating room. It can be done with wire localization, and it's utilized in a number of situations, one of them being if you have discordant findings. So if you have a BI-RADS score of 6, and then you get pathology results from a core needle or fine needle aspiration that does not match a BI-RADS of 6, then typically, you could repeat it, but typically you would just go to excisional biopsy. It's also used if there are any lesions on core biopsy that necessitate an excision, such as atypical ductal hyperplasia, LCIS, radial scars. So moving on to staging, like most other cancers, breast cancer staging is also based on tumor node METS TNM staging system. The overall survival rate we can see here, early stages are pretty good, 99% for stage 0 or 1, 93 for 2, a little bit lower for stage 3, and then stage 4 disease, once it's metastatic, it still is very difficult to treat. So the survival there, the 5-year survival there is still 27%. I'll just briefly talk about the TNM. So here we can see that a T1 is anything smaller than 2 millimeters, T2 between 2 and 5, centimeters, any T2 between 2 and 5 centimeters, and T3 is greater than 5 centimeters. When you get to T4, you're talking about tumors that are extending into the chest wall or the skin. M1 METs, M0 no METs, and then the nodes, you can have, you have no nodes, you have CN1 micromets. So micromets are just very small amount of disease. I think it's like less than 0.2 millimeter of disease when you do a lymph node biopsy. And again, here's the regular staging, so TNM. But the interesting thing about the breast staging guidelines, the latest ones, are that they've started to incorporate receptor status, grade, and gene assays into the actual prognosis. So, for example, if you've got a stage 2A cancer that has a favorable molecular profile, it actually prognostically gets downgraded to a stage 1A. All right, so in terms of surgical therapy, there's two broad categories. You've either got breast conserving therapy, and I include this comes as a package deal with radiation therapy. So breast conserving therapy has been shown to have equivalent survival to mastectomy and typically has a better cosmetic result, but that is only if the radiation part is utilized. If the patient does not want radiation or can't have radiation, then they should not be considered for breast conserving therapy. And then here I've included the contraindications. So multicentric disease, so if they've got multiple tumors around the breast, you can't, just take part of it out. Large tumor size, in relation to the size of the breast, multiple diffuse malignant calcifications, persistent positive margins, because you can't just keep on going back and excising. There's no point at that stage. And then if you anticipate a poor cosmetic outcome with breast conserving therapy, then you would just have the patient go on to mastectomy. For mastectomy, there are a few different types. A total mastectomy removes the breast, including the nipple areolar complex. It doesn't leave much skin behind, so it's typically used in patients who maybe don't want reconstruction. Skin sparing mastectomy also removes the nipple areolar complex, but that does leave behind a significant amount of skin that allows for immediate reconstruction. And then lastly, you've got nipple sparing mastectomy, which actually preserves the nipple areolar complex. This is, it's being used more and more these days, but there are specific indications for it. One indication that I'll mention is like a BRCA patient who wants a prophylactic mastectomy. They're great candidates for this. Any patient who has a breast cancer on one side, but wants a risk reduction procedure on the other side, on the contralateral side, they would be great candidates. Normal patients with breast cancer can also have this, but you just have to make sure that there's no nipple involvement, that it's not too close to the nipple. So if any nipple involvement or nipple discharge sort of are contraindications. And then, you try to do your best to preserve the nipple, but there is, pretty significant rate of nipple necrosis, even so. All right, so management of breast disease is one part of it, but managing the axilla is also a pretty important part of surgical therapy. So the risk of Mets to the axillary lymph node depends on tumor size, location, histologic grade. Now, any patient who comes in with axillary nodes on your exam, they get an ultrasound and a biopsy. If it's positive, no question, you just do an axillary dissection at the time of the surgery. If the biopsy is negative, then again, they get a sentinel lymph node biopsy. If the patients have normal axilla, so no positive lymph nodes on your exam, then they just get a sentinel lymph node biopsy at the time of the breast conserving surgery or the mastectomy. And what happens if it's positive or negative? Let's talk about that. So the Z11 trial is one of the more important trials in the recent years that sort of try to answer the question of, should we do axillary lymph node dissections on each patient who has positive nodes? And as you saw in this previous slide, one of the complications of axillary dissection is lymphedema. So who can we spare from such complications? So they looked at 891 women who had either T1 or T2 invasive breast cancer, no palpable axillary adenopathy, and then only 1 or 2 sentinel lymph nodes with Mets. They randomized them to either just the sentinel lymph node biopsy that was already done, or a axillary lymph node dissection after their initial operation. And they saw that the 10-year overall survival and disease-free survival was pretty similar. So the information that we got out of that is that if a patient has less than 3 positive sentinel nodes with metastatic disease, you don't necessarily need to do a completion dissection. Again, with the caveat that adjuvant radiation therapy will be given, because it's presumed that you're going to sort of control that disease with the radiation. If they have 3 or more positive nodes, then they still get the axillary lymph node dissection. And then the final component of surgical treatment is breast reconstruction. So any breast cancer patient needs to be evaluated by a plastic surgeon pre-op. You have a few different options for reconstruction. You can either do it immediately or in a delayed fashion. Immediately, you could do implants or you could do flaps. Both are good options. Flaps are typically used in a patient who's had prior radiation because they tend to do better than implants in a radiated field. And then a delayed fashion would be something like a tissue expander. You expand the tissue and then go to an implant later on. After you've completed your operation, there's additional consideration given to different sort of systemic therapy. One of that is chemotherapy. Chemotherapy is recommended for patients who have high-risk characteristics, so high-grade tumors, tumors that are greater than 2 centimeters, positive lymph nodes, and a high 21 gene recurrence score. If a patient has triple negative breast cancer that's greater than 0.5 centimeters, they should also get chemotherapy because triple negative breast cancers are a little bit more aggressive and harder to manage. And the typical regimen is taxanes, paclitaxel, adriamycin, and cyclophosphamide. So breast cancer treatment is incorporating more and more molecular testing into its management. So 21 gene recurrence score is a validated prognostic assay. It helps with identifying patients who would benefit most and least likely from adjuvant chemotherapy if these patients are also receiving endocrine therapy with estrogen receptor blockers or an anastrozole. So anyone who's got a low score, so less than 10, no benefit to giving them additional chemotherapy. A high score, then you're assuming they're going to have a more aggressive tumor profile, so they would get a benefit. And then there was this intermediate score of 11 to 25 they looked at. So they compared patients who had just endocrine therapy, so hormone therapy, and patients who had both chemotherapy and hormone therapy. And they saw no difference in disease-free survival or recurrence at a distant site at 5 years. So there was essentially, you don't need to treat these patients with both chemo and hormonal therapy. Hormonal therapy is enough. And then just to go over hormonal therapy, you've got estrogen, progesterone. Tamoxifen is the most common one. It blocks both estrogen and progesterone receptors. This is typically used in premenopausal women, and then aromatase inhibitors block the conversion of androgen to estrogen in the peripheral tissues. The other hormonal therapy is the HER2/neu receptor tyrosine kinase, and that's managed with trastuzumab or Herceptin, and it's a direct antibody to the receptor. And then finally, the last component is radiation therapy after breast conserving therapy or post-mastectomy. Like I said, radiation therapy and breast conserving therapy come as a package deal. So if they have negative nodes, you do whole breast radiation, and then you consider maybe regional nodal radiation. If they've got positive nodes in the axilla, you do whole breast radiation, and then you want to think about giving radiation to the infraclavicular, supraclavicular, internal mammary, and axillary lymph nodes. For more positive nodes, whole breast radiation, and then all of the lymph node basins. Post-mastectomy, sort of similar idea, but instead of everybody getting breast radiation, you are going to radiate patients who have a high risk of local recurrence, so tumors that are greater than 5 centimeters, tumors with close surgical margins, so less than 1 millimeter, and disease in the axillary lymph nodes. And then similar, 1 to 3 positive lymph nodes or 4 more as discussed above. There are a few contraindications to radiation therapy. An absolute would obviously be pregnancy, and then relative are things that would also cause skin issues, as does radiation, so systemic scleroderma, active systemic lupus erythematosus, prior radiation. So any patient who's had prior radiation, you have to take that, and they're not candidates for further radiation. Severe pulmonary disease because of the risk of pulmonary fibrosis, cardiac disease, and P53 mutation, because that would increase the risk of further cancers. Neoadjuvant chemotherapy can also be employed. You can use it if you have a larger tumor that maybe was previously considered inoperative. You can give neoadjuvant therapy to make it operable, and then it can improve rates of breast conserving surgery. You can decrease the extent of axillary surgery, and then you actually have the ability to test the tumor to see if it responded to the therapy you actually gave it. And then another important point is inflammatory breast cancer, as discussed earlier. You're always going to give neoadjuvant chemoradiotherapy first. And then lastly, follow-up. So any patient who had breast conserving therapy has their annual mammograms. Patients who had mastectomy, if it was bilateral, then they don't need mammograms. But if they had one breast, they still have breasts, then they would need mammograms. They don't necessarily need any labs or whole body imaging. And with that, I will hand this over to Francesca. Thank you very much.
So right before we start with Francesca, I just wanted to say Dr. Cruzio did a great job. I just wanted to add a couple of small things just to tie it over. I always am amazed at the breast world with the Oncotype DX and the component of personalized medicine. But remember, that was for chemotherapy specifically, like Dr. Cruzio just mentioned. But it's important to remember because that's really the era that we're moving towards. Everything is being built in that response. With that notion, it's important to note what BRCA1 actually does as a gene. And the concept here is we have homologous recombination. And that'll be very apparent once Francesca Dr. Piccini starts to talk about radiation, how radiation actually induces cell death. And then lastly, unfortunately, radiation, Dr. Cruzio was very kind and she said, lymph node dissections are the predominant reason for lymphedema. Radiation, unfortunately, helps that process as well. And so it's also a risk factor as we move forward. So just something to keep in mind. And all I'm doing is just adding a couple of small things. But with that in mind, I think now Dr. Piccini is going to tell us more about radiation in general and also about a specific paper that went to 15 years of since it was finished, and that's the point in both breast cancer, just like prostate cancer for men, we're in the 15 to 20 year range to look at recurrences, which each cancer is a little bit different. So with that in mind, great job, Dr. Crizuy Fagenderoy, and Francesca, when you have a moment, you have the stage.
I'm ready. Thank you, doctor. And thank you so much, Sarah, for the introductory presentation. Just give me 1 second. Okay, so I'm going to be discussing an article that was conducted on the EORTC trial. The EORTC trial looked at over 250,000 cancer patients and followed up with them on their survival and on their side effects. So in this article specifically, we're looking at the side effects associated with lymph node irradiation in breast cancer, and particularly at 15 years follow-up. So radiation therapy is a treatment modality that uses X-rays, gamma rays, proton beams, and other forms of radiation to destroy cancer cells. When in contact with DNA, ionizing radiation induces double-stranded breaks, which prevent DNA replication and therefore cell division. Secondary effects are also caused by the generation of free radicals, which leads to the oxidation of proteins and lipids along with damage to DNA. And this happens in the form of abasic sites and single-stranded breaks. And overall, the net product is that cancer cells are unable to divide and that the existing cancer cells die due to dysfunctional proteins and free radical damage. So in this slide, what we see is a visual representation of how radiation actually induces cell death in cancer cells. So what you see is with the double-stranded and the single-stranded breaks, you get activation of the p53 system. And depending on how intense the damage to the DNA is, the p53 system could either activate the Bax pathway or it could activate the p21 pathway. Generally speaking, the Bax pathway will lead to apoptosis, and the p21 pathway can either lead to apoptosis or it can lead to repair of the cells and rescuing of the normal cells. But this being said, radiation does also affect normal cells as well as cancer. But the idea is that because normal cells have repaired DNA, have maintained DNA repair mechanisms, they'll be better able to account for the DNA damage that's caused by the radiation. And therefore, you can expect to see lower rates of apoptosis within these cells. The diagram also shows that cancer cells have lower radio resistance in comparison to normal cells. And this might also be due to the fact that cancer cells already have mutations present within their genome, and then the mutations by the radiation compacted on those pre-existing mutations make it easier for the radiation therapy to kill off the cancerous cell. And the idea that's being discussed in the article is that it's the interaction with surrounding normal cells that leads to the side effects associated with radiation therapy. So typically speaking, radiation therapy is delivered as either external or internal beam radiation. For the purposes of this article, we'll discuss external beam radiation because it's the type of radiation that is used in breast cancer. External beam radiation, it suggests that the source of radiation lies outside of the body. And there's 6 different types. Two-dimensional radiotherapy is the one that was used on the subjects in the beginning of our study, and it's where radiographs are used to determine the fields. Later on, when CT scans came out, 3D conformational radiation therapy was used, and this uses CT and MRI scans to determine fields, and this prevents normal tissue from being radiated. Intensity modulated radiation therapy, this is a specialized form of 3D CRT that breaks radiation down into beamlets, and then the beamlets, their intensity can be individually adjusted to hit target tissues. Proton beam therapy is where protons are used rather than X-rays, and this is for patients that have unfavorable anatomy for organ and tissue sparing. So for example, if the heart cannot be repositioned with other methods, proton beam therapy would be used. Neutron beam therapy is similar to proton beam therapy, and it's where neutrons are used, and it's typically reserved for cases where conventional therapy has failed or is very likely to fail. And stereotactic radiotherapy is typically used in brain surgery. It's a very precise method of delivering radiotherapy, and there's multiple examples such as gamma knife stereotactic radiosurgery and stereotactic body radiation. Both types provide high intensity treatment to precise locations, and stereotactic radiotherapy typically requires a lot fewer treatments compared to the other forms of radiotherapy. So when prescribing radiotherapy to a patient, there are a number of factors that need to be taken into account. Again, for this article, we're discussing external beam radiation in the context of breast cancer, and the article that we're talking about will focus on the location of where the therapy is being introduced. But the factors that are considered, generally speaking, are the dose of therapy. So the prescription dose is measured by GY, and it's the total amount of radiation that's being delivered. And that dose typically is broken down into multiple fractions, and that's called fractionation, which is where the prescription dose is given at increments of time to better deliver its efficacy. The location of where the prescription is delivered refers to exactly where the radiotherapy is being delivered, and typically is predicted with CT scans. Concurrent chemotherapy sometimes is used as a radiation sensitizer, and if that is the case, then typically lower doses of radiotherapy are given. And temporality of treatment in relation to resection, this refers to when is the patient receiving radiotherapy. So definitive means that radiation therapy is the treatment, there's no surgery. Adjuvant means that radiation therapy is given after surgery, and neoadjuvant means that radiation is given preoperatively. And in the context of this article, radiation therapy will be given adjuvantly. So radiation therapy for breast cancer typically is prescribed in patients that are node positive or in high-risk node negative patients. There's been an ongoing debate regarding whether or not adjuvant chemotherapy for auxiliary node positive patients is whether it benefits patients to have the internal mammary nodes irradiated, and this is due to the potential side effects. One study initially showed that patients with positive auxiliary nodes who received radiation inclusive of the internal mammary nodes and the supraclavicular and the auxiliary nodes had improved metastatic free survival. But then 10 years later, a meta-analysis that was conducted showed that there was very high levels of cardiac related deaths post-comprehensive radiotherapy. And for the context of this presentation, comprehensive radiotherapy refers to radiotherapy given to the auxiliary, the IMN, and the supraclavicular nodes. And this was particularly true for the 3 oldest trials, and the 3 oldest trials were associated with methods that delivered very high dose treatment to the IMN. Later studies have consistently shown that if you give adjuvant regional irradiation, including the IMN, that there was a statistically significant reduction in distant metastases, breast cancer mortality, improvements in disease-free survival, and incremental cancer control benefit. So because these benefits were seen in 2016, the updated guidelines recommended that the internal mammary nodes be included as part of nodal irradiation, but there still continues to be emphasis on the side effects of radiotherapy with additional emphasis on radiotherapy techniques for managing those side effects. So currently, the radiotherapy techniques that are used to minimize the side effects of radiation, the first one is a radiation dose threshold for cardiac toxicity, and this is calculated using various patient factors, and it's specific and unique for each patient. Heart atlases to guide treatment planning. So heart atlases are typically created using guided imaging to see whether or not it's to determine the fields of the radiation, where exactly the radiation will be delivered to prevent toxicity to the heart. Implementation of breath hold. This is just this is done during treatment while the patient is receiving radiation, and this is done to move the heart out of the treatment field. Intensity modulated radiation therapy and protons. Again, this is for patients that have unfavorable anatomy and for patients that other methods of minimizing side effects haven't worked. And the methods above have been shown to lead to a decrease in 50% of the mean heart dose, which is likely to decrease the side effects that are expected in the future. So in earlier studies, it was estimated that the mean heart dose delivered to patients receiving comprehensive radiotherapy for breast cancer was 4.8 GY, and that there was a linear relationship between the dose and the rates of major coronary events. And this relationship showed that with every increase in GI, there was a 7.4% increase in the risk of major coronary events. This increased to 11.8% in node positive patients. And later studies predicted that the mean heart dose was 4.4 GY, which shows that even though imaging had improved later on, the mean heart dose still remained fairly similar. One study that was conducted on 40,000 women 10 years after treatment, this assessed the excess rates for the excess rate ratios for cardiac death and lung mortality. The estimated excess rate ratio for cardiac mortality was 0.041 per GI, and this corresponded to an excess cardiac death rate of 0.3 to 0.1, from 0.3 to 1.2%. Depending on smoking history, it was higher on if the patient was a smoker. An excess lung cancer risk of 0.1 per GI whole lung dose was associated with long-term lung cancer risk of 4% for smokers and 0.3% for non-smokers.
So Francesca, is it okay if I just chime in?
Sure.
You're doing a great job, and I wouldn't expect you to know this. So GY is a unit, it's called gray, and it's the amount of radiation that's absorbed in a cell per unit length. So the idea is how much dose is being deposited in something. And so usually we have 50 gray for breast cancer, over 70 gray for head and neck. But just so that the group knows what we're talking about when we're talking about dose, you're doing a fantastic job. Please keep going. I'm sorry if I interrupted your train of thought.
Oh, no problem. That's great. Okay, so introducing the article now. with the article. It's known that radiation therapy improves localized tumor control in all patients with breast cancer, and it also improves mortalities in node positive and in high risk node negative patients. However, there is still incongruity as to whether or not comprehensive radiation is recommended for node positive and high risk node negative patients. And this is due to the background history that we discussed, the side effects. The EORTC trial showed a statistically significant reduction of breast cancer mortality with internal mammary and medial supraclavicular irradiations at 15.7 years. And this study looks at a portion of the EORTC trial. And if you want to see the study designs for that trial, they were reported previously. So in this study, eligibility criteria, so all patients were post-mastectomy or lumpectomy, and they had to have a unilateral histologically confirmed adenocarcinoma of stage 1 or 3 with either a central or medial primary tumor, irrespective of axillary involvement, or a primary tumor located in the external quadrants with axillary lymph node involvement. Patients were randomly assigned to receive IMMS or not, and this was at a ratio of 1:1. Center menopausal status, site of primary tumor within the breast, type of surgery, type of axillary dissection, and the pathological T and N stage were accounted for in the research design. The prescribed total dose was 50 gray and 25 fractions of 2 gray over 5 weeks. So sample sizes, these were calculated based on the overall survival. So the overall survival was the primary endpoint. At the beginning of the trial, all patients were assessed for clinical evidence of cardiac or lung fibrosis, and any evidence of cardiac disease using conventional follow-up was scored. After the trial started, a supplemental project was started to give a more detailed evaluation on the side effects. This trial used the common terminology criteria for adverse events to look at the cardiac, esophageal, and pulmonary side effects. And this was done cross-sectionally every 5 years during follow-up. After treatment, patients were seen annually for 5 years, and then every 2 years until recurrence or until death. Data was analyzed using cumulative incidence scores, which were compared using gray tests, and inferential tests were conducted to assess whether or not the difference was beyond fluctuations. The homogeneity of differences across the left and right breast were tested using the fine and gray model. All the tests were two-sided, and a p-value of less than 0.5 was statistically significant. Death was considered the competing risk, and in the study, time to late side effects was defined as the time interval between the date of random assignment and the date of first assessment of the first side effect, and only the first event was taken into account. So this box shows all of the side effects. It's like a summary of all the side effects that were assessed during the annual checkups. So based on, this was done by the doctor, so based on clinical evidence of lung fibrosis, cardiac fibrosis, lung disease, and so on. So between July of 1994 and January of 2004, 46 radiation oncology departments gathered 4,004 patients. The median age of the patients was 54 years old. 34% had stage 1, 52% had stage 2, and 13.7% had stage 3. 76.6% were treated with breast conserving therapy, which includes breast irradiation. Chest wall irradiation was given to 73.4% of patients receiving mastectomy, and nearly all lymph node positive patients, which is 99%, and 66.3% of lymph node negative patients received adjuvant systemic treatment in the form of chemotherapy or hormonal therapy. IMMS radiation was given to 97.1% of the patients randomly assigned to receive it, and 41% of the patients randomly assigned not to receive it. So this is just a diagram showing the eligibility, how the patients were selected, and the patients that were excluded, their reasons for exclusion. So at 15 years follow-up, the incidence of lung fibrosis without IMMS was 2.9%, and with IMMS was 5.7%. The incidence of cardiac fibrosis without IMMS was 1.1%, and with IMMS was 1.9%. And the incidence of any cardiac disease without IMMS was 9.4%, and with IMMS was 11.1%. There was no statistically significant difference in the incidence of competing risk, which was death, and this was in the absence of cardiac fibrosis or cardiac disease. And there was no difference in cardiac side effects between the left and the right-sided breast cancer. So this is just a table showing the side effects that were recorded. As you can see, based on the p-value, these effects all reached statistical significance. So at 15 years follow-up, the cumulative incidence of lung fibrosis was 2.9% without IMMS versus 5.7% with IMMS. For cardiac fibrosis, it was 1.1% without IMMS and 1.9% with IMMS. And the incidence of any cardiac disease was 9.4% without IMMS and 11.1% with IMMS. There was no difference in competing deaths, so it was the same thing. Okay, so this is a flow diagram showing the cumulative incidence rates. So for lung fibrosis, the rates for both increased pretty steadily over time at an equal rate. Similarly, for cardiac fibrosis, however, for all cardiac diseases, the IMMS group and the no IMMS group, they progressed pretty steadily for about 10 years. And then at 10 years, the group seemed to split, and the no IMMS group did have lower rates, but for 10 years they had very similar side effects. So
just one more thing, it's very important to note the y-axis on there. So even though we're talking about differences, we're looking at 5, 10, 15%, and the absolute differences are about 1.7%. So it's just important to note, because these were the big issues about toxicity and why this paper is so key and why we're looking at it. But keep going, Francesca, I'm sorry.
Exactly. Okay, so taking on the results of the supplemental trial. So the summary for any side effects after 15 years. So without IMMS, you have 2.5% versus 3.7% with IMMS for pulmonary side effects. You have 3.9% without IMMS and 4.5% with IMMS for cardiac side effects, and 0.7% without IMMS and 1.1% with IMMS for esophageal side effects. 77% of the patients were alive at 5 years, and 61% of patients incidence probabilities of clinically relevant scores of 2 or greater. So clinically relevant scores of 2 or greater, these were scores that had side effects, that presented side effects clinically. So 0.1% of patients without IMMS had clinically relevant side effects versus 0.8% of patients with IMMS. 1.8% of, and this is for pulmonary side effects, 1.8% of patients without IMMS had significant cardiac side effects, and 2.6% of patients with IMMS had side effects. And then 0% of patients without IMMS had esophageal side effects, and 0.1% of patients with IMMS had these side effects, which shows that the presence of clinically significant side effects is very low. And this chart is showing that as well. And as you can see, for late cardiac morbidity, there's no incidence for 10 years, similarly to the other chart, and then that increases after 10 years. Okay, so there was 563 second primary cancers, which is 14.6%, and 6.6% of those were contralateral breast cancers. There was no difference in the frequency of secondary cancers between the two groups, but the IMMS group did have a lower death rate of 15.5% versus 18.7% in the patients that were not treated with internal memory radiation. And the rate of unknown causes and missing data was higher in the nodal irradiation group. So the nodal irradiation group had 2.1% versus 3.4% in the other group. So overall, the study shows that there are very low rates of side effects with small differences between the treatments, between the treatment arms for all side effects. The cross-sectional study provides additive information that verifies that acute side effects of radiation therapy are reversible during extensive follow-up. And because this study was conducted before CT-based treatment, cardiac doses could not be predicted. However, patient selection was guided towards women bearing a low baseline risk. Introduction of new techniques and preventative treatments will help further reduce these cardiac side effects. And this goes, obviously, treatment techniques have evolved and there's been a decrease in cardiac doses compared to the past. And this is mostly due to better planning and planning in the form of using CT scans to properly map out the heart. And this is predicted to decrease the risk of cardiovascular mortality. And when you combine with low rates of side effects and the absence of excess non-breast cancer related mortality, the validity of proton therapy for breast cancer is put into question. So proton beam therapy might only be needed for very special cases. And furthermore, the field of cardiology itself has evolved, and this provides more applicable treatment in preventing and treating radiation-induced heart disease. The risk of radiation-associated secondary cancers is well known, and this is especially true if the patient has risk factors such as young age or smoking, and this typically happens in the contralateral breast, but in this study it was not observed, and this is likely due to the fact that all patients in the study received radiation of at least the chest wall or the breast. So strengths of the study include the high quality data for a large number of patients during a very large follow-up. There was extensive quality assurance program linked to the trial. There was a real international multi-centric contribution from a wide range of patients. So this increases the applicability of the results because it gives you a diverse demographic of patients. Limitations, there was no quality of life evaluation for the patients, and quality of life is obviously a very important, it's a very important factor to consider in cancer survivors. Unbalanced amounts of missing data and unknown data between the treatment arms was present, and the use of radiation techniques during the beginning of the study from 1996 to 2004 are now considered outdated. That's what I was talking about at the beginning of the presentation. With contemporary volume-based radiation therapy, the outcomes are expected to improve, and this is due to improved coverage of target volumes, increased homogeneity of dose delivery, and decreased delivery to non-target tissues. And again, this is done using imaging to better guide where the radiation goes, and improved radiation technology. So this study found better breast cancer related outcomes. So there was 73% survival after 15 years, along with lower rates of side effects compared to other studies, which challenges several assumptions about balancing the risks associated with radiation treatment for breast cancer. It's likely that both the relative calculated risk increments using data from other studies, along with the absolute baseline risk in the contemporary population, is overestimated. Estimates of cardiac events don't provide insight on the clinical morbidity of the event and the impact it has on the patient. This is because the majority of side effects had a reported score of grade 1 with no statistically significant differences in the incidence of grade 2 or higher events. This means that most patients were asymptomatic or will be asymptomatic, and therefore improved monitoring, early detection, and treatment of radiation-induced cardiac diseases is important to minimize the clinical effects of toxicity. Currently used risk estimations should be reviewed using contemporary data and details about outcomes for improved patient selection. So this here is a chart showing the manifestations of radiation-induced heart disease and what the treatments should be. And the idea is if you treat pericardial effusion, constrictive pericarditis, etc., before it progresses to cardiac fibrosis, the patients will have lower rates of morbidity and lower rates of long-term side effects. Thank you.
That was fantastic. So I just want to point out a couple of small things, because one of the things that people always ask me, especially patients, say, you know, Dr. Bjarke, why is this 5 weeks? Why is this 7 weeks? Why do we treat radiation for so long? And I think Francesca and Sarah did such a great job. The reason goes back to the 60s, and where they looked at fractionation and the effects on cancer cells. versus the effects on normal cells in terms of cell death. And so what was found was that delta, the change between the effects on cancer cells, was highest at around 2 gray per fraction than if you looked at normal cells, meaning the normal cells had a chance to repair, whereas the cancer cells continued to die off. And that's the constant sort of balance a radiation oncologist has to put together. So we're constantly trying to see how we can affect cancer cells the most and normal tissue the least. And these two young doctors, it's an honor to work with them. They're incredibly bright and incredibly hardworking, and both had an impressive presentation. So all that we're talking about here is, can we provide a good treatment? Because, you know, thankfully people are living 10 to 20 years with this. So how do we provide this? And is radiation a viable treatment or not? And as you can see, the positive aspects are high, the rates are low, but that doesn't mean we need to forget about them. Even though it's 1 to 2%, it's very crucial to understand that, you know, folks that are living 15 to 20 years past radiation treatments, that we need to worry about their cardiac risks. Now, thankfully, they're not very serious, but that doesn't mean we need to forget about them. So with that, I really want to applaud, because the presentations are fantastic. And you know, my radiation residents would have had a tough time to try to do the same thing. So fantastic. It's an honor to work with you guys. And if there's anything I could ever help you with, please don't ever hesitate. So with that, I'd like to open it to the group. If there's any questions that we can answer, if anything was unclear, or if somehow we help with the presentation. So the floor is open.
Hey, great presentation, Sarah, Francesca. Thank you, Dr. Block. I have a question for you. So this study was done, I mean, this study goes retrospect 15 years ago, right? Aren't the methods, the intensity of radiation now different compared to 15 years ago?
Absolutely. The study, so if it's okay, Sarah and Francesca, is it okay I answer this question?
No worries.
That's exactly correct. And so currently we use things called intensity modulated radiation therapy. We utilize CAT scans, we utilize MRIs, and these are helping us really hone in. I think the surgeons in the group are going to laugh at me, but we think of radiation very similarly to surgery. And the concept is, we're looking at a precision. We're trying to make sure, and the technology is advanced. And so when we say IMRT or volumetric arc therapy, we're utilizing, so for example, for volumetric arc therapy, we're looking at a circle of 360 degrees, and we're providing radiation every 2 degrees. So 180 entrance points. And what ends up happening is we have these leaves, these tungsten leaves that shape the beam. And the leaves are automatically generated and moving in an appropriate way. And in a very simple way, if I want the radiation beam to look like a banana, it'll look like a banana. So the opportunity to avoid dose to the heart, especially, you know, in right-sided breast cancers versus left-sided breast cancers, the opportunity to avoid dose in the skull base, where I like to live, away from optic structures and so forth. These become crucial. So our technologies have grown immensely, and we can even argue that 1.7% of cardiac risk may actually even be lower. And you have to remember, this was done at a time where you can't even predict what dose those women, so there's 4,000 women in the study, you can't even tell what dose they got.
Oh.
Currently, we say we want 4 gray or less. Back then, it was what it was. Now, what's important was that meta-analysis that Francesca mentioned. It gave a bad name to the field. And it said, radiation is causing more cardiac, and it was an unfair argument, because when often meta-analyses are not done appropriately. And so what ends up happening is you get the data that's already been sort of worked out, and you're not getting the raw data that you're combining, you're getting the data that each group looked at, and then you're combining that. And so there's a lot of statistics, damn statistics, right? I mean, that's what people always talk about. So we always have to be wary of that. And so what's nice about this is it's a prospective phase 3 trial with good follow-up that helps us really start to understand what are those toxicities. And as you saw, most of them were grade 1 and 2, which means our patients wouldn't even know that they're happening. For lung fibrosis, they may just be radiologic things that they're experiencing, but really no differences in shortness of breath or anything in their lives. But I would argue, and as we look at the newer trials that are moving forward, the problem is we have to wait 10 to 20 years, as Francesca showed us. So it's hard to do this. And so, but that's a great question.
Yeah. Okay. I have a couple more, but I'm waiting for someone else to jump in.
I just wanted to ask, so a lot of the chemo, so both Herceptin and Adriamycin cause cardiac toxicity. How does that confound sort of radiation therapy?
It's a great question. And often they're not done concurrently. And so that's a great question, because that's exactly the point. And so often we're the bad people. Because we have this big word, radiation, right? And it's like, and you're gonna be an aspiring surgeon, right? The first thing you're gonna say is, radiation ruined my planes. Radiation's terrible. If this wasn't an irradiated site, and then what I'm gonna say is, well, you're an academic surgeon. What do you want me to do? How do you want me to help you? So what's important to note is that in cancer, just like anything else, it's team ball. And it's that interplay between the three groups that becomes really crucial. So tumor boards are important. What are the techniques we're using in radiation? What chemotherapies are we utilizing? So that Z11 trial is fantastic, right? Because until that Z11 trial, all lymph nodes were coming out, right? And then you showed a beautiful picture of one versus the other. And the point is, and I would tell my patients all the time, it's not just surgery that causes side effects, and it's not just radiation that causes side effects, and it's not just chemotherapy that causes side effects. It's the three modalities together. And that's the interplay that we have to, but your point is perfectly, correct in that it's sort of it's a combined multifactorial component of all of these side effects. Great question.
Thank you.
Sarah, question for you. I'm kind of going to go a little bit off topic. It's still breast cancer, but since I'm internal medicine, I care about the preventive part. I was listening the other day to some news, and then they're saying that there's been like drop down on screening of breast cancer because of the pandemic, 80 to 90%, especially on 2020. What is it that they're doing to achieve to raise the numbers? Any data on that?
Yeah, no, you're absolutely right. That people have missed their screenings. I'm not sure I think other than just raising awareness and trying to educate patients that it's okay to go back and get your screenings. I've seen plenty of like hospital emails that have gone out and things like that. But yeah, I mean, a lot of people dropped their last year or two. I think, based on overall data, just because you missed 1 year of a mammogram, as we saw, isn't going to make a huge difference. Overall, you can do every 2 years if necessary.
Right.
But most practitioners would follow that yearly mammogram rule. And I think the benefit to the individual patient is probably better if the earlier you can catch something, the better it is going to be.
Yeah. And I'm thinking with these health fairs that we are organizing, the Albanian American Medical Society, I think it should be one of the pamphlets about the breast cancer screening. It's pretty important. I think that should be like our next project.
Yeah, absolutely.
Yeah.
I have a question for Dr. Blockhead. Great coordinating the presentation and giving insightful information about what's going on. you don't have to answer this question, but I was just wondering whether you're been in touch with the breast screening awareness in Albania and how the community there has perceived breast cancer and the screening, and how big it's here in the States versus there.
So I've had the fortune of being invited a couple of times to Tirana to give a couple of talks. Most of my talks have, I mean, I'm a head and neck and skull base and CNS radiation oncologist, but I can tell you that there's a lot of great work being done there. And every year I go back and I see people, I've made some great colleagues, and it's very impressive. Folks have trained elsewhere and come back. As you know, I can talk about my own family, right? I can talk about my own aunts, and regardless that in our family, my father, my mother, my uncle, we're all physicians. I don't think my aunt has ever gone for a mammogram ever in her life, and it's just part of. There's this component of it's just cultural that I think we as a society need to do better and better. I mean, I used to go, in Nod Burave, and they would throw me 3 cigarettes. And really, I used to say, how about you throw me some apples? throw me something that I'm gonna really be excited. But these are the things that little by little, I think we have to start to pitch away at, you know what I mean? And little by little in a nice way, in a way that's constructive, because people aren't trying to be a certain way. I think what you learn in our field is you're dealing with everything, right? You're dealing with folks that, so for example, now with vaccinations, it's become such a political question, right? I just got my third booster today, and I was so excited that I could get it because I had a Moderna vaccine. And so, but it took us, our family, almost 2 months to convince my aunts to do this. And it's not because they don't love us, it's just these misconceptions. And I think what we need to do as a society, and Nora, you're leading the way here, is to continue. And I love, how I've seen the group go, because I follow you guys on LinkedIn and I see it. I'm very proud of what you guys have done. And I'm, hoping to be more and more involved if the opportunity is there. But, going to discuss with folks and trying to be partners. And then, like you said, Edion, to try to really raise that awareness, and provide this, cultural opportunity to make some sort of tangible change, so that we're not waiting, till the last moments to see somebody. Because the sooner we see, I mean, like Nora said, by the time you get to me, I mean, I hope you never get to me, right? And someone's like, wow, what kind of doctor are you? If I never get to you, you never get paid. And I said, well, I hope I'm smart enough so that I could do something else. That's okay. But it's a great point, and it's something that we have to just keep working on.
It's my impression that the medical community is well aware of it. And as you said, the society itself has a hard time accepting the fact that they need to be screened to prevent malignancy. And I think that's where the problem arises. There's such a huge agenda everywhere in the world, United States included. We've dedicated a month about breast cancer. There's so much talk in the media and whatnot, but I don't feel the society back home really understands that they can prevent this, that a DCIS can be cured, and so on and so forth. And I also feel it's a disease for the rich back home. I don't know why I'm obsessed back home, but but a lot of us have ties back there, and that's why my talk is connected with that. But that I also feel like it has to be more accessible to the masses, and I don't know how that can be changed.
Fully agree. And that's, radiation is very expensive. And to be in Albania and to have 4 radiation oncologists for the whole country, that's difficult. And, a few of those radiation oncologists have been to Ohio State, and I'm proud of that because they've been here for anywhere from 2 to 4 months. And the idea is to help as much as possible to provide that change. But I really do, even from year to year, there's been some great strides. And I'm excited about that, and I'm hopeful, and And, the fact that you're asking that question is huge as well. Because, obviously you're thinking about it, which means the folks around you are thinking about it, which means your colleagues are thinking about it. And we as a society are thinking about it. And that alone is an achievement. And I think that's how we need to just move forward and continue to contribute in a positive way. Thank you for your question. I didn't get it.
Absolutely. It makes me proud you went back home to raise that kind of awareness. Good job.
I'm going to keep trying. I'm going to keep trying. It just depends on who wants to listen. That's the problem.
It's always the problem.
Definitely not politicians.
No, I stay away from them. So I just can't. Any other questions from anyone? This was great. This is late. You guys have stayed an extra 20 minutes. I'm thankful, and I'm going to try to do a better job of joining in the future myself. So thanks for putting up with me tonight.
Well, thank you so much. Thank you, Dr. Blackeye, Francesca, Sarah, great job.
Yeah,
This was
they've done an
much
awesome
needed. Yeah, I learned so much about radiation therapy now.
Well, can you imagine? I mean, what Francesca and Sarah just did, it was great. I mean, the whole concept of anatomy, the whole concept of prevention, and then finally treatment. And we did it all what do we do it in 80 minutes? That's pretty impressive. And it's an honor to work with such young, bright physicians. The future is fantastic for us, and I'm very excited. Thank you so much.
Okay,
Thank you
thank
so much, Doctor.
Thank you so much, Doctor, and Sarah, and Francesca.
Thank you, Dr. Nora.
Okay, good.
Good night.
Good night.
Nathan Emir, Miro Bavshim.
Nathan Emir.
Olivia.